lose money. I mean, it's going to depend on the situation, but there are some very specific reasons why they're going to be winners, even if other vendors in general tend to be losers. I forgot the little piece of trivia here. Who am I? Why am I here? That comes from Admiral Stockdale in the 1988 vice presidential debate, when he got up there with the real vice presidential candidates and basically had no idea why he was there. He'd been a friend of Ross Perot's, who had been recruited to serve as the interim VP while Ross tried to find somebody to take his place. Other publications, if you name the publication, my metrics have been in it. Most recently, Harvard Business School did a case study, and we will be sending you these slides if you want to buy the case study. It's up to you. Unlike my books, I don't get any royalties on them. You will see that I am the person whose numbers used by the Validation Institute are considered the gold standard. So we just took a poll while we were waiting to see how many people think their vendors measure validly or not. Now, unfortunately, not a lot of people got on that poll before we started, but this is a somewhat skeptical crowd, which is good. Even though it's somewhat skeptical, speaking of the word somewhat, validly won the poll. And we're going to re-poll at the end of this session and see if you still feel that way. So I don't know if you can see the results. I think you need to, maybe I can turn them off here. I don't know if I can turn them off, Larry.
Can you see the results there?
Yeah, I've seen the results. I think I'm sharing the results.
Okay.
Can everybody see the results? No, we don't want to do either of those. So
why don't you just repeat what the results are there?
Oh, okay. So the results are that, the poll was done before people basically got on, but 3 of the 5 put somewhat validly on the choices between don't know, largely invalidly, and validly. And that's par for the course, although usually we get a couple of validlys. So I don't know how to get this thing off of my screen.
Just hit escape.
Okay, there you go. All right. So what we're going to do before we jump into this is I'm going to challenge the group here. If you find a material mistake, not like a misspelling or anything, if you find a material mistake, you will win an e-copy of my 3rd book, which is called Surviving Workplace Wellness with Your Dignity, Finances, and Major Organs Intact. So be on the lookout for that and hit the chat box if you think you find a mistake. And to make it more interesting, I'm actually going to plant 3 mistakes in this presentation, okay? But before we get into it, let's start out with some trivia because we're at the intersection of health and wellness, which is a specialty of my day job, Quizify. Those of you who don't know Quizify, imagine Jeopardy meets health education meets Comedy Central. We're teaching people to be wiser consumers of healthcare by creating trivia quizzes for them. So at the intersection of health and wellness and arithmetic, which is exactly where we are today. And so we'll take a look at some quantitative facts that come out of a #1 New York Times bestseller called The Book of Useless Information. Healthcare information is not useless. Page 99, Dunkin' Donuts serves 112,500 donuts every day, which no doubt contributes to our obesity problem. And speaking of obesity, on page 103, it says how Americans consume 10 million tons of turkey on Thanksgiving Day. And this has caused a large increase in obesity, especially among youths. According to the CDC, cut and pasted off their website, 1 in 5 youths aged 2 to 19 years was obese, meaning that their BMI was in the 95th percentile or above. So with that trivia in mind, let's launch the show. We're going to start with how not to measure outcomes and ROI. Do we have something in the chat box, Larry?
No, they had. Emily is not familiar with the movie.
Okay. All right. It was my cousin Vinny, and Vinny kept referring to youths as Utes, and Fred Gwynn, who was the judge, had no idea what he was talking about. All right. So before we go on with the show, and by the way, thank you for indulging me in this digression. But I'm going to say, why did I just show this trivia from the #1 best-selling trivia book and from the CDC? The answer, the reason I showed it was that all those facts are dead wrong. They're not even close. They're off by a huge amount. And yet no reader, no reviewer, no editor noticed. The book's been in print, actually at this point, for 12 years, and the CDC left that quote up for 10 years before I shamed them into taking it off. So let's look at how these things were wrong. But first, the point I want to make is that everyone assumes that if experts say something, it has to be right. So I showed you all those qualifications, right? I showed you all of, the articles and the books and everything, but never assume that something is right because someone, including me, tells you so. Because everyone has an agenda. And frankly, my agenda is to get you to be more interested in what I do, Consultants want to convince you that everything is so complex that you need to pay a lot of money to have their quote unquote teams handle your RFPs and evaluations for you. As we will see in the case of workplace health centers, that is not the case. You can do an 80-20 rule using ingredients you have in your own kitchen. Vendors want to convince you they are saving lots of money, whether they're your vendors as workplace health centers or whether you are on this call as an employer and you're evaluating workplace health centers. And my favorite quote is from my friend Dennis Angelis, who recently retired as CMO of Presbyterian Health Services. If every vendor got me the ROI they said they got, I'd have negative medical spending. So I'm going to tell you not to listen to a word I say, but to believe your own eyes, okay? Do your own analysis. I'm going to show you how. So watch what happens when you do your own analysis instead of believing what the experts tell you. And let's take this Dunkin' Donuts quote, 112,000 donuts a day. You say, wait a sec, there must be thousands of Dunkin' Donuts stores. That's only a few dozen donuts a day per store. And when I was a kid, I could do that in a single sitting myself, right? Wait, hang on a sec. Oh, here we go. And let's take the quote on Americans consuming 10 million tons of turkey on Thanksgiving Day. Then pause to reflect for a second. 10 million tons is 20 million pounds, and that's 20 billion pounds, and that's 100 pounds per person. Okay, that's a lot of leftovers. And if you look at this quote from the CDC, 1 in 5 youths aged 2 to 19 years was obese, meaning they were in the BMI 95th percentile or above. How can you get 20% of youths into 5 percentiles? The answer is you can't. Now, if they had said, we set the growth charts up in 1979, I might add it was my very own uncle who set them up. And compared to 1979, 20% of youths are in the 95th percentile above where it was 5%. That would be a legitimate statement. That's not what they said. All right. Let's now really get on with the show. So we're going to show how not to measure ROI. There are many ways that vendors put their fingers on the scale, and we're going to show 3. And by the way, you don't have to take notes. We're going to send you this. You're going to have live links. You're going to be able to rely on this as much as you want. We're on the record. I'm being recorded. Everything I say, I would say to anybody who I use as an example here. Let's start with regression to the mean. Regression to the mean is the tendency of samples to become less extreme as sample size increases. So let's take the baseball standings from April 28, 1988. And the reason I'm using that is Baltimore set a record by losing its first 21 games. So the difference between Cleveland and Baltimore was 0.762, from 0 to 0.762. Now, fast forward to the end of the season, and the range between the #1 division winner and Baltimore had slipped from 0.762 to 0.216. That's regression to the mean. Now, over time, higher ones generally decline and lower ones generally increase. It's not true for every single individual, but for populations as a whole, they regress to the mean. Some vendors have weaponized RTM. So this is an example of RTM from a carrier proposal. They guarantee that 30% of the so-called worst employees, using their term, high and medium risk, will improve using their program. Okay, so you can see the high and the medium risk go to medium and low risk, and by about 30%. But there is no mention of the low risk people who got worse. Shouldn't they be counted in the guarantee? Let's go back to the standings of the AL. Now, in fact, Toronto and Milwaukee that were both below 500, meaning low, meaning in this case, I don't know, high, whatever you want to call it, they went from being below 500 to being above 500. So people regress in both directions. Now, in case people still aren't convinced, let's use an example of smoking cessation using this methodology, okay? So let's have a smoking hypothetical. Suppose everyone in your organization smokes and quits in alternate years, and for simplicity, smoking is the only risk factor. So 50% of your organization smokes every year, but it's a different 50% each year, all right? This methodology would find a 100% reduction in the smoking rates every year, even though the smoking rate remains unchanged. Now, let's recall the brochure. And the question is, do you think this omission in this brochure, forgetting to put the low risk to high risk people, was deliberate or was just an oversight? And okay, well, I think it's going to be pretty clear. I was going to say, Larry, while they're doing this, do you have any, actually, we do have, we're getting votes for honest mistake here as well, but it looks like it's pretty overwhelming in favor of deliberate fabrication. So I'm going to end the poll and share the results and hit the escape key. And the answer, of course, is it's a deliberate fabrication. Now, normally, if I do this live, I ask for a show of hands, hence Reese Witherspoon. How do we know this was a deliberate fabrication? Well, the answer is that in order not to draw attention to the low risk people, they smushed 2/3 of the employees into 1/3 bar. And they used bubbles. So each of those bubbles represents 10 employees. So they did that so they could be arithmetically correct, at the same time trying to hide the fact that, in fact, 2/3 of employees are low risk. I mean, they probably have risk factors, but there's no way of knowing them because they're subclinical. So I'm going to give an example from a real vendor here. This is a vendor that I will happily take credit for driving out of business, called Interactive Health. They kept me very busy. Every time that they would say something, I would point out how much of an obvious lie it was. We could go back and forth a few times until they went into chapter 7, and then I had a lot more free time on my hands. All right, so they have 4 categories of risk: high, elevated, moderate, and low. And they had 2 data points a year apart. And the first data point, as you can see, that's this vertical bar here. 57% were low risk, 10% were high risk, and everyone else was in between. In the second data point, they had a slight improvement in the low risk and a slight reduction in the high risk, and everyone else was in between. Now, the way you know this is mostly regression to the mean, if not all regression to the mean, is that the red represents lower risk people who got worse between the 2 measurements, and the green represents higher risk people who got better. So the people who were at high risk, you can't get any higher than high risk, so half of them stayed the same, half of them got better. Low risk, number of them got worse, and the large majority stayed the same. And Interactive Health concluded from this that 85% reduced or maintained their risk, and they're charging a ton of money. So they said this was a great outcome. Now, I might add, by the way, that they did not count dropouts, and about 20% of people dropped out. And the reason you drop out is you're not doing well, and it's worth getting fined or losing your incentive not to participate in the second time around. But let's just assume that they're right. They could easily have said, using the exact same slide, that 79.7% of people either stagnated or got worse. So basically their net improvement was 5% or something like that, for which they were charging like $5 million or some huge sum. So you were paying, I figured it out, for every pound that employees lost, you were paying about $1,000. So I would normally do a poll here, but, or actually I'd get a show of hands if we were doing this live, but which of the following vendor RFP claims are just reductions to the regression to the mean? The most obese employees in our program lost 20 pounds, pure regression to the mean. At the Validation Institute, we get this all the time with weight loss companies coming to us and saying how much their heaviest people lost. Well, of course, their heaviest people lost weight, but guess what? Some of their lighter people gained weight. We get a reduction of 1% in participants with high HbA1cs. Once again, HbA1c doesn't stay like this, it goes like that. So the high ones, some significant number would go down on their own. The total percent of employees with high HbA1cs will fall by 20%. That is legitimate. If you had, I don't know, 1% of your total employees with an HbA1c over 9, and a year later, you've managed to get essentially everybody to be screened again, and this time you have 0.8% of your employees over 9, doesn't matter if they're the same ones or not, that's not regression to the mean. You actually did something at that point. The percent of high-risk employees improving will exceed the percent of high-risk employees deteriorating. Now, remember we talked about low risk going up and high risk coming down. And so if you do this, it would appear that you've adjusted for regression to the mean. Only it turns out that number 4 is really regression to the mean, even though the carrier makes it look legit. How do you know that this is just a lie? And by the way, these are all carriers you've absolutely heard of deliberately lying, just for the record. And the only reason I'm not naming names is because some of them are qualified customers. So let's take that statement. Percent of high-risk employees improving will exceed percent of low-risk employees deteriorating. So let's look at the high risk. Now, if 20% of those high risk improve, that's 26 people. If 10% of those 670 low risk get worse, that's 67 people. So if this vendor had said the number of high risk employees improving will exceed the number of low risk employees deteriorating, that would have been legit. But of course, they didn't say that because they know full well that wellness loses money. How does this affect the way you measure your savings for ons? Oh, I said clinics. Sorry, Larry. I thought I changed it all to centers. You know, there's no find and replace button on PowerPoint. So I just went through all the slides, and I think I must have missed this one. You can't just start with the people with high risk factors and then manage them. Oh God, the word clinics appears 3 times. This is really embarrassing. Yes, a clinic-based wellness vendor will do a better job than a traditional wellness vendor, but regression to the mean creates a glide path that will overstate savings. Because remember, the people who you're going to find, clinic or center or non-center based, are as a whole, if you're starting out with high-risk people, they're going to come down. Later on, we'll show you how you can measure centers validly using, as we say, ingredients that you already have in your kitchen without complexity. So that's regression to the mean. Let's do participation bias, which is also a lot of fun. Now, this is a slide that won an award from the Wellness Industry Trade Association. It's called the C. Everett Koop Award. And if you see a vendor that says they won one, you basically immediately exclude them from your RFP because essentially they all make up their numbers. And this is a perfect example. So this was a slide that the C. Everett Koop people said shows how much money gets saved in wellness. So they have the participants versus what they call reference group, what we would call the non-participants. The participants go up at the blue rate in cost. The reference group, the non-participants, go up at the red rate in cost. So you look at that and you say, of course, this is brilliance. The participants did vastly better than the non-participants thanks to the wellness program, which is what they wanted to say. But once again, this is where we would ask for a show of hands. How do we know that this slide actually proves exactly the opposite of what the wellness industry would have you believe that they proved? Well, the answer is if you look really hard at the x-axis, you can see that the savings, they separated the groups in 2004, and due to the typical wellness industry incompetence, they didn't actually get started until 2 years later. And this is really This shows anything, we call this a smoking gun because it essentially invalidates the entire industry with this one slide. The participants were already dramatically outperforming the non-participants before the program even started. The separation was huge. Now you might say, well, maybe the program had something to do with it in the out years. If you actually look at the risk reduction, there was hardly any risk reduction. The program had nothing to do with it. Pure participation bias. And the way you know that is that they tried to cover it up. So the trade association's leader, a guy by the name of Ron Getzel, wrote that the x-axis was unfortunately mislabeled. And then he claimed the program started in 2004 and therefore all the savings should be attributed to the program. But then the people who actually did the program said, no, Ron, that's not the case. You need to put the axis back. The program started in 2006. So it's not just a smoking gun, but in this particular case, the behavior of the person in charge of wellness basically proves that they know full well that this stuff doesn't work. So we had 3 claims of 4. I think we had 4 before, but we get a reduction of 1% in, these are all actual quotes from wellness, from vendors. We get a reduction of 1% in participants with HbA1cs over 9. Once again, the word participants is a giveaway. We will reduce the total percent of employees with high HbA1cs by 20%. No participation bias there. The only thing you have to be careful of there is that the total percent of people participating in your screens stays about the same. They don't necessarily have to be the same people. That would be a really nice to have. But if you're getting 80% of your population doesn't want to lose $1,000, and so they participate in the screen in year 0, and only 40% participate in year 1, then number 2 is out the window because likely the people who didn't participate the second year were the ones who got worse. But if you get, say, 60% both years, or 70% the first year and 65% the second year, this is a legitimate statement. And then this one we already know actually is not a participation bias, but rather just regression to the mean. And let's show you some more examples. This is a diabetes vendor combining both regression to the mean and participation bias. You got to give them credit. It's hard to get both biases into one sentence. 90% of participants defined as having a quote unquote critically high HbA1c were able to decrease their HbA1c to under 8%. So that might be some kind of record for the most fallacies in the fewest words. Yet another diabetes vendor, reducing average hemoglobin A1c by 0.8% for all study participants, including a 1.4% reduction in those above 9. Once again, combined participation bias and regression to the mean. This one is just pure regression to the mean, an average decrease of 39 points in total cholesterol for people with high cholesterol. They didn't tell you, maybe, I would be impressed if this were like everybody who was over 200, but I guarantee you, since they didn't say it, it's probably like everyone who was over 400 or something. And of course, other people went up during the period. So the 4 rules for participants versus non-participants, this methodology always far overstates actual impact. Now, there could be impact. There are a lot of point solution vendors that I think do something worthwhile, but probably 80% of them dramatically overstate what they do because they're just looking at participants. And in order to even qualify for them, you have to, be high HbA1c or high risk, or be about to get a surgery or something that puts you very high on whatever scale they're measuring. Now, you're going to see the words passive control, match control, propensity score control. They're all the same thing. You can't get inside people's heads. You can't compare active, motivated participants to inactive, non-motivated participants, non-participants, or even to a passive group that includes people who might have participated and people who might not have participated. So these are the 3 rules. I said there were 4. In case a vendor disputes rule 2 or 3, see rule 1. And always ask, as we learn from interactive health, how did you measure the dropouts? Okay, now the complexity of measuring participating in centers is harder, and we will come up with a solution for that toward the end. So I hope everybody intends to stay on to the end. Now, in addition to these biases and measurement that you just saw, you have to ask, what constitutes participation in on-site centers? Is it the number of visits? Is it the exclusive use of center doctors as PCPs? Is it getting a checkup? How about somebody who really likes it, but has no need to go to the doctor? So you can essentially eliminate all this stuff, and we'll talk about how to do that at the end and how to measure without the complexity and get kind of to an 80-20 rule of whether your on-site center is doing anything for you or not. Now, let's compare to trend, which is also fun. I have to say, it's more fun talking about all the bridges that blew up than the bridges that actually stayed intact. So a perfect example of trend inflation was the North Carolina Medicaid study, where this was a huge, this is the biggest patient-centered medical home ever. And it was billions of dollars. And they hired Mercer to quote unquote evaluate it. And when you hire an actuarial firm, you're going to get the result you want. That's the whole point. That's the whole point of hiring them. So they had 6 categories. And let me just show you what they did on the next slide. They compared the projected benchmark trend spend to what actually happened, and they saved this massive amount of money. Now let's take these numbers, and to make them easy to understand, put them on a graph. Now, as you can see, every single category of savings, inpatient, outpatient, emergency room, they combined primary care and specialists because both went down, and you don't expect primary care to go down, or they went down versus trend. And you would expect in a patient-centered medical home that primary care would go up. So in order to obfuscate that fact, they put them both together. Pharmacy and other. In every case, everything went down. Now, those of you who read my book, which statistically speaking is about, let me see how many of you are on here. It's about 1.5 people. There's a line in there that says, if you insulate your house, you'll save money, but not on insulation. So my question is, where is the insulation expense? Where are people getting their care if they're not getting it inpatient, outpatient, the ER, the doctor, the pharmacy, or anywhere else? Well, the answer is that you simply just take a trend and you draw a line and you say, we save money versus trend. And in fact, the consultant who published this, a fellow by the name of Seth Serksner from Mercer, said, now I underline the word choice myself, the choice of trend determines the savings. So forget about how much you actually saved. If you want to show more savings, you just show a higher trend. Now, ultimately, the state figured this out, that in fact, the consultants were lying, because even though they were saving all this quote unquote saving, these massive sums of money, every year, the Medicaid folks would come to them toward the end of the fiscal year and say, the 4 words that you least want to hear in any kind of business setting, oh, by the way, we need an emergency appropriation because we missed our budget this year. So once the state saw, I published an expose on this, and once the state saw it, the program was gone in a couple of years. So much more recently, there's been a perfect example of this, which is, like I say, you hire an actuarial firm you hire actuarial firms to fabricate savings, not to validate savings. If you want savings validated, you simply go to the Validation Institute. It costs much less, and they have what's known as a credibility guarantee, which means they stand behind their numbers. So this was a study that Aon did for Accolade, and people basically just reprinted it without looking at it hard. And it showed that Accolade saved this massive sum of money. In fact, the sum of money was 8.3% versus trend, the control being the green, and then they cherry picked some clients to be the blue. And they said they saved, they went from $250 higher per year, higher than the control, to 185 degrees lower. So they saved 8.3% in 1 year. So the question is, how can you tell this 8.3% savings claim is largely trend? And I'm going to show you And once again, if this were live, we do it interactively, which is why it has the question number up there. And I'm going to ask you to remember the Sherlock Holmes quote, Watson, you see, but you do not observe. We are going to observe. So let's take these 4 comorbidity groups. People have absolutely nothing wrong with them. People have a little wrong with them, and then 2, 3, or 4 or more. And the savings are over on the right, 8, 9, 11, 1 in the wrong direction, 14, for a total of 8, well, it says 8%, 8.3%. Let's put them on a graph. And the first thing you notice is that Accolade's magic seems to work when you have 0 to 2 things wrong with you, but when you have 3, I guess, you know, whether the calls come in and they get screened and someone says, do you have 3 comorbidities? Person says, yeah, I have 3 comorbidities exactly. Oh, can't help you, bye. But if you have 4 or more, Accolade seems to do very well. So we're going to do one thing first. We're going to take these last 3 groups, which are a minority of the population, as is always the case. The vast number of people have nothing wrong with them, and it goes down, you know, pretty quickly after that. Each is less than half of the previous one. So we're going to combine these 3, weight average them into this yellow here. And then we're going to weight average these 2 blue things, the people who had nothing wrong with them or a little bit wrong with them, and put them together in one bar. And what you see is that nothing happened. 0. It might be 0.1. So the people who had absolutely nothing wrong with them, which was the vast majority, probably didn't even know who Accolade was. And the people who had one little thing wrong with them, according to Accolade versus Aon versus trend, saved in quotes exactly as much as people who really did have a reason to call Accolade. And you know, basically nothing, there was no difference between the two groups. And my favorite example here is upper GI esophageal, where there was savings of 7%. So I'm just imagining these calls. If somebody calls Accolade, says, yeah, you know, my esophagus is acting up again. What should I do? And they say, oh, that's easy. You know, just take some pills. I don't know what they say, but who is going to call Accolade when their esophagus is acting up? And by the way, if you have heartburn, indigestion, Quizify has tons of remedies that are very easy. One of them is you simply, if it's nighttime indigestion, you simply put your bed on an incline. And if I were in the bedroom right now, I would show you my bed is on an incline. And I used to get indigestion and I don't anymore. Case closed. Guarantee you nobody at Accolade is telling people that. Guarantee you that nobody is calling Accolade and saying, what should I do about my esophagus? So how do you combat this in a workplace health center? Well, first of all, you're going to measure units of utilization and focus on the specific units that you lay out in advance rather than sort of shop afterwards for the units that went down. And then if in fact you're saving money per visit, you're going to measure prices separately. You're not going to hermaphroditically combine utilization and prices. They're 2 different things that get 2 different measurements. You're not going to talk about participants or high risk or trend. You're going to zero in on the units. So having finished this section, let's do another poll. How many people now think, okay, yeah, all righty. So now we're getting some, oh wait, no, that was the previous poll. So while we're waiting for this one to come in, yeah, this is, yeah, I would love to know these folks who still think they're vendor. I mean, the thing is, it depends which vendor you have. If you have vendors that are, frankly, if you have Quizify, or if you have vendors that are validated by the Validation Institute, you're gonna get some generally valid results. The needle did not move as much as it usually does. We went from the significant majority saying somewhat validly to the majority saying largely invalidly, but usually I get much more of a movement here. So I think people are either using better vendors validated by the Validation Institute, or else they were maybe multitasking. All righty. So I think I don't know if I share can everybody see the results? I hope so. All right. So yeah, so largely invalidly wins. So now let's talk about valid measurement and examples for clinics. We're going to show two examples. One is RCTs and cluster randomization. The other is total event rate. We're not going to have time to show waitlist controls, but I'm going to leave you with a link that talks about how you can use a waitlist control. Two links, actually. So let's just do the first two. There's only been one actual RCT done in wellness or prediabetes. It was a company called Newtopia. And it was a subject of an article called Genetic Testing May Be Coming to Your Office Soon. Now, they did both an RCT and participants versus non-participants for the same population. They split the population into control and invited of similar characteristics for a one-year study. Then they invited people who were in the essentially to be invited group into the program, and some small number accepted and completed the program. The next page will show you this graphically. So the first two groups, program group 1 and program group 2, were invited into the study. The control group was left out. Remember, all these people had the same, the same everything that they could tell on their claims. So this would, if you do this comparison, that's an RCT, comparing a control group to an invited group where nobody raised their hand to participate ahead of time, or else everybody raised their hand to participate, and some were chosen and some weren't. In this case, it was nobody. So if you compare those two groups, which Newtopia did in a footnote, you find that basically it was about nothing. If you read these 6 items that they compared, there was essentially no difference between the control and the invited groups. One was slightly statistically significant, which was triglycerides. 3 of them, glucose and systolic and diastolic blood pressure, actually went in the wrong direction. Your glucose went up more if you were in the invited group, and your blood pressure went down less. So basically nothing happened. But if you, same population, mind you, if you compare the control group to the enrollees, the small number who actually finished the program, which is what Newtopia did, having buried the other thing in a footnote, you get massive savings. $1,464 dollars per person who, and if you looked at the study design, it excluded people who actually were already diagnosed with diabetes or heart disease. So they managed to save all this money on people who had nothing wrong with them. And a member of the, actually it wasn't American Journal of Managed Care, it was the Journal of Occupational Environmental Medicine, publicly apologized for publishing this result and burying the RCT. And I give it an example to show the dramatic difference that you get when you do these things. Now, the cluster randomization is another example of an RCT. This time was BJ's Wholesale Club, where they picked 20 randomly selected clubs to participate versus 140 control. And the idea of a cluster randomization, which is going to be the case, by the way, in workplace health centers, is that even the people who aren't actively in it somehow benefit from the patina of having these things. So in the case of BJ's, it might be that the person in the treatment center club, is having, tofu and broccoli for lunch, and the other person they're with is having, hamburger and fries, and says, gosh, that tofu and broccoli looks awfully good. Maybe I should try that. So the idea is that there's this patina. And remember, everyone is in the same organization. So there's no regression to the mean, no participation bias. Everyone is counted in both clubs. And the answer was nothing happened, basically. Nothing at all happened. I'm not going to go into it in great detail. So let's look at the total event rate, because this is, you can actually do this. Oh, yeah. I'm sorry. Oh, God, I said clinics again. Randomized control trials or cluster randomizations is easy for centers if you have more than one site. This is not an ERISA issue. If you were going to do a regular study, you would need to get an IRB, Investigational Review Committee approval. The HR folks would have to approve it. No, you're perfectly fine, as long as you don't change the benefits of having a center at one large facility and maybe not having them at your smaller facility. So then you can compare the metrics at one site to the others, where at one site, people have access to the center and the other site, they don't. And then you just do a difference of differences analysis on the metrics. And we will now show you what the metrics are. You're going to look at total event rates, meaning the metrics. Now, how do you do an event rate analysis for common chronic disease? You apply these ICD-10s to your entire population, and we're going to send you this. You don't have to write it down. For primary coded ER and inpatient events, and these are people who fell through the cracks of the center. So you're measuring this the way a manufacturer would measure a defect, measure quality, but kind of looking at the defect rate. How many people did you not catch before they infarcted or had an asthma attack or whatever? This is a screenshot from the Validation Institute. We'll send you this thing if you want to do it yourself. You simply, using these ICD-10 codes, you fill in the ER and the inpatient rates, you add them up for a total event rate, and guess what? You get an answer. You might get something like this. This is pre-pandemic. I'm not going to get into post-pandemic because it bounces around a fair amount. But this is, for instance, in 2016, out of every 1,000 belly buttons that you covered, 3.7 had an ER event or an inpatient for asthma. So these rates are generally pretty low. There's a lot of talk about chronic disease, but the fact is a lot of people don't end up in the hospital or the ER with a primary diagnosis of one of these chronic diseases. You have a total of about 260 people a year going to the ER, maybe 220, going to the ER or the hospital. 10 or 15 will be going with one of these conditions. You put it up on a graph and you get something like this. Now, these numbers would have to be significantly different for the people who had access to the clinic because they were at the right work site versus people who didn't, or over time, these numbers are going to fall. If you only have one site and you put the clinic in. Now, the fact is they fell during the pandemic on their own. So there's nothing you can do about that. It's kind of tough to measure that. So really measuring people with access versus without is the way to go. So total rates of metrics are the way to go. You have none of these three biases. You're looking at the total. So there's no regression to the mean. And it's not just chronic disease. There's a lot of thought about chronic disease, but in fact, what you're really, I think you're going to find that the savings are in avoiding, it says ER visits, ER and urgent care visits. They should be falling. And they're very easy to measure, although there's the pandemic bias, unless you're doing a comparison. These are folks who, if they need stitches, can go on site instead of off site. Total PCP visits should stay close to even, as opposed to people just getting more medical care because it's easier to get, which is very common. There's going to be some of that, but the question is how much? Total specialist referrals and scans, things like extra tests, extra referrals, should decline because presumably these folks can take care of a lot of things in-house, and a typical PCP is making more money per hour if they just refer things out than if they try to solve the problem themselves. In productivity, it's very simple. Just take how much time you think it takes to get a medical visit on site, compare it to how much time it takes to go off site. And I'll leave you with a question. What else would you measure here? I remember you're trying to do this simply without complexity. Measure things that are easily measured and intuitively tell you and arithmetically tell you whether money is being saved. You don't have to come up with an exact ROI. You just have to prove that, in fact, the value of the program exceeded the cost, the value of the center exceeded the cost of the center. And there are other soft benefits. So if you can just actually even break even, employees like these things. When you're showing people around, and they like it. Nobody doesn't like it. And the productivity, very specifically measured, how many people are going off site. That's a thing, that's easy to measure. We're not going to do the wait list control. I'm going to leave you with that. Use this as a way to check how your vendor is measuring outcomes. I'm putting Quizify in. We use total events, total ER, total things we measure are like things that are dramatically overused, like stents and scans and spinal fusions and that kind of thing. Find out whether your vendor is doing these things. The green ones are valid, the red are not. Other questions to ask: are you validated by the Validation Institute? If not, does your quote unquote independent actuary offer a credibility guarantee like the Validation Institute does? Spoiler alert, they don't. All righty, so we have time for some questions. Larry, what do we have?
Okay, so what I'm going to do now is I'm going to go around the table as we typically do, and I'm going to invite people to ask questions or comments. And I'm just going to call upon you based on how you show up on my screen. So Bob Grumman, Bob, any comments or questions? And I'm going to take you off mute. Bob?
While you're waiting, someone
Go
said
ahead.
Cleveland Clinic saves $180 million in wellness. No, they don't. What they did, which was very smart by their point of view, is they've sort of only recruited people who they think are healthy, and they try to scare people away who aren't healthy. So like there's no McDonald's on site kind of thing. So it works very well for them, but it's not because of the program, it's because of what they do for their population. So more power to them, but they didn't, wellness doesn't do anything. And their particular vendor, Bravo, has been proven time and time again not to do anything.
Okay. Chris Birch, Chris, any comments or questions? Chris? No? Okay, David Kite. David, any comments or questions?
No, thank you, Larry.
Okay. Elizabeth Caffrey, any comments and questions? Elizabeth?
No comments.
Okay. Emily Starr, is Emily, any comments or questions?
No comments, thank you.
Okay. Ian Covington, Ian, any comments or questions for you?
Nothing here, thank you.
Okay. Gene Griffin, Gene, any comments or questions? No. Okay. Katie Lang, any comments or questions, Katie?
Sure, surely somebody must have something that they're going to challenge this on, or
We'll see. Mark Savage, comments or questions, Mark?
Nothing for me. Al did a great job as usual.
well, thank
Okay.
you. You can see me blushing on the screen here.
Stephen Henson, Stephen, any comments or questions? No. And finally,
Can you hear me? I'm sorry.
Go ahead.
Oh, yeah, great. Just a question to your question, other metrics that you might want to measure. What about clinical quality measures in totality, like you were talking about for the ER and admit and other metrics, but what about clinical quality metrics over time and maybe even clinical outcomes?
Well, the outcome should be measured by the chronic disease event rates, because that is the ultimate outcome. If you wanted to come up with some others, more power to you, but you just would have to set them up in advance, and they'd have to be something you can measure either the entire population on. You can measure the entire population on. So, did you have any in mind?
No, that makes sense. What you're saying about the ultimate measure is the inpatient and ER related to those chronic conditions. That makes sense. I think we can, you're not getting at the source of it when you're looking at the quality. So is the quality, in fact, getting the better outcome? But you're saying just kind of look at the outcome, which is the ER rate and the admit. So I appreciate that.
Yeah, and trust me, as someone who's been in this field for 30 years, it's much, much easier to measure the outcome. Besides,
I agree.
Yeah.
I agree. Yeah. Thank you, Al.
Tina Halliday, Tina, any comments or questions? All right. Well, Al, I've got a question. I mean, we know a number of the centers, when they're doing their reports, avoiding unnecessary care and comparing the cost of the community care to what the cost is at the center are often used. Can you comment on that?
Yeah. So that was actually in there, that you separate price from utilization. And if in fact it's costing you considerably less per visit, which it should, particularly when travel time is taken into effect in a center than off-site, that is absolutely an element of savings. I mean, even if you make no change in anything else, that's a savings. And whether it's enough of a savings to pay for the capital cost, another question, but absolutely.
And you probably you've already commented on this, but a lot of the centers and employers, they look at people who utilize the center versus those who don't utilize the center. And as you'll have our guidebook up. For those who are not aware, the NAWHC has this guidebook for measuring the performance of worksite centers, which covers many of the questions and issues and challenges in measuring, as well as listing out metrics for the different VOI approaches of quality and cost and productivity, engagement, participation, satisfaction, etc. But Al, could you talk about the comparison of participants who are actually using a center versus those who don't, and showing the value of the results of the center?
Well, if you're looking at outcomes, that's simply not valid. However, if you want to measure the satisfaction with the entire health benefit, it is perfectly valid to compare people who've used the on-site center to people who haven't. And if they have a significant difference in satisfaction, you can absolutely credit the center with that.
And how do you recommend an employer shows the value of the center in the total spend of the organization? What's the best metrics to use for that?
Oh, well, I mean, that you could take some of the things we talked about, like we talked about the difference in price, we talked about the difference in productivity, we talked about the being able to reduce the chronic disease event rate and apply a standard cost to an ER visit or an inpatient stay. And then it's fairly easy. I mean, I've read through the guidebook. It's got a lot of great stuff in it, but it's not 80-20. It's not 80-20. This is 80-20. It's fairly easy to then figure out if your center gets above that break-even point. I guarantee you all the soft issues go in favor of the center. So really all you have to do is show that you're above break even, and people, the folks that write the check should be very happy with you.
Okay, and lastly, on virtual care, it's an area that we want to add to the guidebook. Many of the telehealth and virtual care vendors talk about savings from people not going to the emergency room or urgent care center because they use their service. Could you comment on that, or any metrics that you think are either valid or not valid for virtual care?
Yeah, I mean, I've done a lot of analyses of these virtual care and talked about your induced demand. I mean, I had one situation where they surveyed people at the end of the call and said, would you want to go to the emergency room? Would you have gone to the ER absent this? And they got so many people who said yes, that it was actually more than the number of people who went to the ER in the previous year, and the number of people who went to the ER in the previous year stayed basically the same that year. So you cannot ask people. All you got to do is just measure the number of ER visits and urgent care. And if that's going down significantly, and you're not getting a lot of induced demand, you're not getting a lot of sort of more spend on, these calls than you otherwise would get, you're actually doing something.
Okay. All right. Well, thank you very much, Al Lewis, for your time. And thank you all for the participants who came on today. As Al said, copy of the recording and the slides will be available and sent to everybody who participated, and will be posted for our members on the website. With that, I want to thank you all for participating, and look for our next upcoming program. Nothing at this point is scheduled for November or December, but we have an annual program in January in Scottsdale in person. Hope you can all participate, and look for the newsletter for meetings, because we will be rebroadcasting many of the most popular sessions from our annual forum during the year. So with that, thank you all, and have a good week. Bye-bye.
You want to stay on for a second?